Great. Fantastic. Welcome, everybody. It's October 26th. I'm Joanna Katzman, and this is our infectious disease office hours. Many of you are in New Mexico, and many of you are in many states all over the US, and some are even from farther away than that. Again, I'm a neurologist. I'm at Project Echo, and I'm also at the UNM Pain Center. Wanted to introduce my colleague, Carla Thornton. Carla, do you want to unmute and introduce yourself?
Sure, thanks, Joanna. Hi, everyone. Carla Thornton, infectious diseases faculty at UNM.
Great, thanks, Carla. Just a few housekeeping items before I introduce Dr. Nestor Sosa, our kind of leader of this program, and our other hub facilitators. If you don't have a camera, we understand that. Please perhaps come on next week where you have a webcam. But if you have the ability to turn on your camera right now, please do so. It allows for better kind of bi-directional teaching. We can see you and you can see us, and it allows for more community of practice. The other thing is we do have a digital librarian today. It's not Kent Noseworthy, it's Jackie Jones, who will be putting in evidence-guided, evidence-based material into the chat that you can just copy and paste the information that you desire into your own browser. And then lastly, at about 45 minutes after the hour, you will be getting information in the chat about a CME link that you can acquire your no-cost CME. And if you don't need that, please feel free to still fill out that form, as we do really look at this information very carefully. I'd like to turn it over to Dr. Nestor Sosa. He's the Division Chief of ID at the UNM Hospital, and he's really led this program weekly since the end of March. I think we're about 32 weeks into this infectious disease office hours for the COVID-19 pandemic. And then after that, I'll introduce our other hub team members. Nestor.
Thank you. Thank you very much, Joanna and Carla. Let me share the screen. Okay, can you guys see my screen? Excellent, good. Okay, so before I go into the papers, I really want to, make everybody think, how the number of cases are going up in the state of New Mexico and in the US. And I think we have to double our efforts, spread the word about the different prevention methods. There's no really room for COVID fatigue. It's really, I know it's difficult. We are all tired, but the numbers are really going up, not only cases, but also hospitalizations across the state. So I think it's important to double our effort and do it rapidly before it becomes really a geometric increase in the number of cases, and then we have to go to emergency measures in the hospitals and those sort of things. So I think it's important to continue the effort that you have done for so many weeks, and now more than ever, because we're seeing a large number of cases everywhere, not just here, not just in the United States, but everywhere. Okay, so I'm going to go into some of the papers that actually interesting papers that I saw, and there is and I want to mention this, give some light to another antiviral that we haven't really used or considered much in the West, but it's being used and studied in Japan, and it was actually approved in Russia for use against COVID. And I asked the question: is favipiravir the next remdesivir? There was a study on animals showing the potential for these antiviral, which is similar in its mechanism to remdesivir, but it's oral, and it can decrease the viral load, and hopefully will have some place. And there are some large trials coming up in the near future with remdesivir. So this study was actually in animals, and I'm going to, bear with me. I just want to show a couple of ideas with this experiment. So this was done in mice, in hamsters, and the good news is that we have now a good model, animal model in small mammals. We have been using non-human primates and ferrets, But this Syrian master model is pretty good to test new drugs and also to do all sorts of virological study. So the way they did here, they actually pre-treated the hamsters with this favipiravir, and actually they use also hydroxychloroquine, and then they exposed the hamsters to an infectious dose of SARS-CoV-2, and then they follow them for several days, did CT scan of the chest, cultures of the lung, PCR of the lung and other tissues. And the interesting result was with favipiravir, which are basically the first 4 colors here: gray, yellow, orange, and red. And they show the higher the dose of favipiravir, the smaller the amount of virus in the lung. So it showed sort of a dose effect. And this dose, 1,000 milligrams per kilogram, are doses that, according to the authors, can be achieved in humans. So at least this drug in animal models showed to be effective. And the other thing that I think it's just another nail in the coffin of the hydroxychloroquine, they also gave these hamsters hydroxychloroquine, and you can see that it's, the viral loads are very much similar to the control hamsters. So there's no effect of hydroxychloroquine, and this is basically prophylaxis. The other nice experiment, which I think it's really creative, they actually pre-treated a group of hamsters with the drug and infected a second group, and then they put them to live together. So this is like, to see if there is any pre-exposure prophylaxis, and then they sacrifice these hamsters and actually compare if those who were taking the favipiravir were protected, and in fact they were. And I'm going to just go, the one this is again the viral load of the infected and non-infected but treated mice, the one with the circle, and you can see that the empty orange circle, which is a pre-treated hamsters, as I keep saying mice, but hamsters, these pre-treated hamsters were actually protected or had lower RNA PCR in their secretions compared with the untreated or with those treated with hydroxychloroquine. So this drug was not only as pre-exposure prophylaxis, but also prevent natural infection. So it's interesting, the data from these favipiravir. We have to wait obviously for the human studies, but at least it's something that it's coming down the pipe. We are going to start here at UNM a study with a similar molecule called MK-4482. It still doesn't have a name, but we're going to use it early on and see if it has antiviral effects in humans. It's going to be a phase 2 study, and I think it's going to start in a week, maybe 2 at the most. The other study that I wanted to mention, there is a review for those who have asked questions about the how long does the RNA shedding last? How long do patients actually excrete viable virus? There was this nice review. It's going to be published in Infection Control and Hospital Epidemiology. I think it's a pre-publication or an accepted manuscript, in which they review 77 studies. And basically all of the studies that have been published with good data on RNA shedding and viral culture in patients. There were actually 12 studies with good quality data on viral culture. And they added all these and data analysis, and their conclusion was that the RNA shedding goes on for an average of 18.4 days. So more or less 3 weeks rounding up. But there were some patients in these 77 studies, a few that had a long period of RNA shedding, and you can see the record was 92 days. So it's really slightly more than 3 months of RNA shedding in these studies, basically in respiratory secretion. They also look at viral shedding in stools and other tissue, and they found that you can find RNA in some of these studies up to 55 days, with the median duration 22 days. So not very dissimilar to respiratory excretion. So that's also important, and that's what we're using the so-called wastewater epidemiology, because you can use the excretion of the RNA in the stools and then going into the sewage water as a measure of or detection of these viruses. And then viral viable virus or culturable virus or infectious virus, if you want, it's much less than RNA. And then the range is between -6 days, so 6 days before symptoms, and 20 days. So the longest excretion really in the majority of the patient did not go over 20 days. And obviously 20 days was for those with severe disease. And that's why the CDC has the recommendation that if you have severe disease, you have to isolate for 20 days. If you have mild disease, for 10 days, because really viable virus is excreted relatively for a relatively short period of time. In fact, RNA was up to 45 days longer than actual viral shedding, and a similar phenomenon occurred with viral shedding in the stool. So this is an interesting paper for those who want to really look at like sort of a summary. It's not really a systematic review, but a summary review of the papers that have been published about viral shedding. I found it very, very useful and easy to read. Another paper that I liked was an effort to classify COVID. You know, we have been talking about prolonged COVID, long COVID, and it's sort of, there's sort of a disorganized number of names. So these authors actually, they publish in the open journal of IDSA, the Open Forum for Infectious Disease, and they propose actually 3 classifications, very easy. Acute COVID, which is what we know, the patient in the hospital, those first 3 weeks, and they go all the way to 3 weeks from the time of infection to the COVID. Obviously, in an ICU patient, that could go on a little bit longer. But then after the patient recovers from acute COVID, they call it post-acute COVID-19. And that's from 3 weeks, basically, to 3 months. And anything beyond 3 months, it's a so-called chronic COVID. They propose this classification, and I'll show you graphically what they propose. So they have the acute COVID or acute SARS-CoV infection. And remember, there's a NIH classification of asymptomatic, those who have no symptoms; mild, those who have no oxygen requirement; moderate, those who require oxygen, but they have more than 94% O2 saturation and at sea level. And then severe when it's less than 94, and critical when they require ventilatory support or non-invasive ventilation. So that's the NIH for the acute. And then they call anything beyond 3 weeks or beyond hospital discharge for those critical patients, it's called post-acute COVID. And they actually classify within this post-acute COVID the multi-inflammatory syndrome in children. And then those patients, they mentioned they have persistent symptoms and persistent organ dysfunction. And that's what we need to study. What are the symptoms that really are frequent? What are the organ dysfunction? And that's what we have been reviewing. And then if you go beyond 12 weeks, so 3 months, then you call whatever symptoms you have chronic COVID-19, because it's beyond this period of between 3 and 12 weeks. And that's what they're proposing in the Open Forum of infectious disease. And this is basically the way they say with the organ dysfunction, the most common organ dysfunction in this post-acute COVID are pulmonary, cardiac, thromboembolic, neurologic, and renal. Obviously, that's the majority. There are a few other organs that are affected, but these are the most frequently affected organs. And then the symptoms, and they review several of the publications that we have seen, and we have even reviewed some of them here, are fatigue, respiratory symptoms like dyspnea, cough, arthralgia, sleep disorder, concentration, and memory loss. Obviously, you can have both. You can have pulmonary dysfunction by objective data like DLC2, CO, or pulmonary function test, and you can have cough and dyspnea. So it's not one thing exclude the other. They're actually together in this post-COVID. But I think it's a good way to see it as objective organ dysfunction or just subjective symptoms, and these are the most common in their review. So I'll give you just a brief update on therapeutics. The trial that came out, and I think came out as a pre-publication, but it was commented by many people, and I think there was somebody in the audience, I forgot exactly who was the person, but asked a question about this solidarity trial. This is a trial that it was organized by the WHO, and it's sort of a real-life trial. They contacted many countries, and they actually asked them to collect data on the treatment, different treatment for COVID-19 since the beginning of the pandemic. So they actually tested several treatments. They ended up having 405 hospitals across the world, 30 different countries, more than 11,000 adults enrolled. And obviously they tested remdesivir, hydroxychloroquine, Kaletra or lopinavir, interferon. And some patients did not receive any specific drugs, and those were sort of the control, but they didn't use a placebo. And this was not a double-blind study. It was mostly like, as I said, as a real-life comparison of different treatments across many countries, many hospitals. And in fact, the WHO didn't pay for the trial, so it was done with the own resources. So there's some variability between the treatment received in a country, let's say in Latin America, compared to a hospital in Europe. So that gives some limitation to the conclusion. But the message is that none of these drugs, remdesivir, hydroxychloroquine, lopinavir, or interferon, change the mortality or progression of disease in this study. And actually, you can see the relative risk are very close to 1, 0.95, 1.19, 1.0, 1.16. So no effect of none of these drugs in this study. And you can see the Kaplan-Meier, very close, the control group to the treatment group in the different arms. And you can make an argument that hydroxychloroquine and interferon were actually worse than the control, although not statistically significant. And regarding remdesivir, something that made a little bit of noise in the US was that, in fact, for ventilated patients, actually remdesivir was numerically inferior to the control, but again, the P was not significant. So no difference between remdesivir and the control. But again, this study is not as good as the Beagle study that was published in the New England Journal because of the methodology. There are some limitations to this trial, but nevertheless, it's more information there available for us to judge on the effectiveness of these drugs or efficacy of this drug. There were actually 2 negative trials on tocilizumab, one a randomized control trial published in the New England Journal. Just to remind everybody, tocilizumab is an IL-6 inhibitor, and the thought, because at the beginning of the epidemic, we were really concerned about this cytokine storm, and IL-6 was sort of the center of the cytokines in this cytokine storm. The idea was that we could use an IL-6 inhibitor that was already available and used for other diseases, sort of repurposed to use in COVID-19. And this is the first relatively large trial. They actually evaluated 1,500 patients, but they ended up enrolling 161 in the arm of tocilizumab. 81 received placebo, almost in a 2-to-1 ratio. And you can see the Kaplan-Meier survival. This is ventilation, mechanical ventilation of death. And you can see that you cannot really separate one line to the other. No effect of tocilizumab. And there was another publication also with no impact in mortality in JAMA Internal Medicine about the same drug. So at least we have 2 relatively large, well-designed, well-executed clinical trials showing no benefit from tocilizumab. There are still some other trials, but at least it's obvious that it's not a miracle drug by any means. And these are the discontinuation of oxygen and other parameters. And again, you can see that the curves are very, very close. Both the placebo and the tocilizumab are very, very similar. And finally, this is sort of basic science stuff, but I just want to share these because we have been throwing these comments in, and especially now that we're going to be seeing the efficacy and safety of vaccines, there have been historically 2 mechanisms in which a vaccine can actually make the disease worse. And I wanted to show a nice graph that explains these 2 mechanisms. One of the mechanisms is the so-called antibody-dependent enhancement. So antibodies to a previous infection, making the disease, instead of better, worse. And the other one is a phenomenon that was seen with RSV, with formalin inactivated RSV vaccines in children many years ago, and it's called the vaccine-associated enhanced disease. And I'm going to try to explain it very simply. So this is the antibody-dependent enhancement. And how could this happen? How could an antibody that is supposed to protect us enhance the disease? And this is the mechanism. So first of all, this is a macrophage here, and this is a virus. And these have been described mostly with dengue virus, but it has also been seen with some coronaviruses, not with SARS-CoV-2, with some other coronavirus. And the story goes that you produce antibodies there are no neutralizing. They don't kill the virus, they don't destroy the virus. And the macrophages have receptor for this portion, the so-called FC portion of the antibody. So actually, these receptors actually capture the virus and help the virus go into the cells because they are not destroyed, they go into the cells and then they multiply within the cells. So they actually, the fact that the virus is coated with non-neutralizing antibodies makes it easier for the virus to find a cell, to enter and infect the cells, even without using the typical or classical spike protein ACE2 receptor. So that's the mechanism in which scientists think that these enhancements occur. And this occurs with dengue because dengue has 4 serotypes. So if you get infected with one serotype, you develop this non-neutralizing antibody that do attach to other serotypes and help the virus actually infect cells. And that's why the second episode of dengue, if you have dengue 1 and then you're infected with dengue 2, the second episode is most severe. So this is one of the concerns that people have, that in theory, this could happen either with natural infection or with vaccines. And it's something that obviously scientists are looking into. And finally, the other mechanism is the vaccine-associated enhancement. And in this case, what happens is if you use, and this was the case of RSV, respiratory syncytial virus, that was inactivated with formalin, there was a change in the fusion protein, which is sort of the spike protein of the RSV, and antibodies attached to this dead or inactivated virus and was deposited in the lung. So there was sort of an immune complex deposition of this dead virus with the antibodies, with the inactivated antibodies, and then the immune system, specifically the T cells, recognized this deposition of immune complexes and then produce an inflammation of the lung. So it was actually the kids who got the vaccine, some of them got really worse with the vaccine than with natural infection because of this activation. And that's why we are looking for this type of reactions to the vaccine, the Th2 reactions with the vaccine that have been tested, because this reaction to the immune complex is mediated by Th2 with the release of some cytokines that actually produce lung inflammation. So those two details, I know it's completely interesting to understand. And this is what the Data Safety Monitoring Board and the scientists that are looking into the safety of vaccines are also looking, not just the usual, pain in the site of infection, fever, but actually a more worrisome immunological phenomenon that could make a vaccine worse than the solution, like the vaccine worse than the prone except. But this has not been described so far with any of the vaccines or with the SARS-CoV-2. So we are optimistic that this is not going to happen. But I just wanted to give you the sort of in-depth understanding of this phenomenon. Recommended reading for this politically charged environment. There were 2 nice comments. One called the false promise of herd immunity, that I invite people to read. And this is a photo from Salvador Bahia. I'm sorry, not Salvador, Manaus in Brazil. Manaus had an infection rate or very high, over 60% of the population of that town in the Amazon of Brazil became infected, and they have to open mass graves, and that's the risk of herd immunity, and that's what this paper in Nature actually talk about. And it's sort of a comment on the courage in the climate of fear, how healthcare workers have really faced this epidemic with valor, with really courage, and how we expect from people who actually are in power to also be courageous and take the measures necessary to curtail the epidemic. 2 nice reading that I recommend. That's it. Thank you. Sorry that I took a little bit long time.
Dr. Sosa, no problem. It's always amazing. We learn so much every time. Yeah, as Fred was saying, thank you. So much great information. I could ask you a ton of questions, but I'm going to move on to introduce Marla Sievers, our amazing senior epidemiologist from the Department of Health. I think Marla has some updates for us. Marla.
Thanks, Joanna. Good afternoon, everyone. Just one brief update I wanted to bring to everyone's attention in case you missed the press release last week, but flu season has officially begun in New Mexico. We have confirmed our first flu cases in New Mexico. So in addition to being on the lookout for people with clinical signs and symptoms of COVID, which we've been focused on for months now, we are now back officially in flu season. It remains to be seen how severe of a flu season we will have. Hopefully it will not be very severe and there won't be much flu transmission, given that the masking and the social distancing that everyone should be practicing for COVID prevention should help prevent influenza and other respiratory viruses as well. But just wanted to make sure that clinicians were aware that we are seeing flu activity in the state now. There is a weekly flu report that is published on our website, so you can check back there weekly. It is updated every Friday, where you can see all of the national and statewide trends for influenza tracking in New Mexico. And so we track confirmed cases through laboratory reporting. We also do syndromic surveillance for influenza-like illness. And all that information is up there on the website, along with some information about the different methodologies to track syndromic cases, ILI surveillance, and laboratory confirmation through Sentinel sites. Thank you, Nestor, for your reminders about COVID fatigue. I think everyone is aware we've been experiencing our highest number of new cases for the last couple of weeks now. We're really sort of, this word gets overused, but we really are sort of in an unprecedented time here in New Mexico for COVID transmission. We've never seen new case counts this high. And, it's not just a function of increased testing. We really are seeing symptomatic people who are being hospitalized. And if you've followed the daily press releases, you can see that our number of deaths is starting to pick up as well. Thank you.
Thanks, Marla. I want to let you know that Dr. Hayes is not with us today, and neither is Carissa Culbreth from the New Mexico TRICARE lab. They'll both be back with us next week. Marla, I wanted to just ask you a couple questions. Heather Brislin, I think you answered Heather's questions. Is there a place online through the DOH where you can track flu trends? And you answered her questions. And Fred Fox asked, how is funding for COVID response holding up at the state level? That was a question. Wanted to see if you might be able to answer.
Yeah, I don't have sort of all the details about the different funding sources and where things stand from a budget perspective in New Mexico, but obviously we had that influx of federal funding early on in the pandemic. That hasn't really been renewed. No new funding has come to the state, so we are definitely aware that a lot of that influx of funding through the CARES Act has been depleted at this point. But I don't have sort of the bigger picture idea of what that impact is on the state budget or where other funding sources might be coming from.
Thank you, Marla. And one more question to you, Marla. Given the kind of uptick in cases all around the state of New Mexico, are schools are going to change their plan to to have any kind of hybrid situation, or going to remain virtual for the time being?
I think largely many of those decisions are being made at the school district level. So for example, Albuquerque Public Schools said a couple of months ago they would not resume any in-person learning until after the first of the year at the soonest. Other districts have gone ahead with their hybrid model. And if you look at the Public Education Department website, you can see some of the documents that have been developed to guide schools who are having in-person learning about when they may need to quarantine students, how students are being cohorted, and what thresholds have been created for deciding that a school that's opened to in-person learning might need to close. And so that's all sort of driven by the number of school associated cases, and if those are among in-person or distance cohorts. So it's very much a work in process. No one has sort of this figured out. We're looking at other states who've come before us with in-person learning, how they've handled school outbreaks, And I think, we get varying information from week to week as new studies are published about how children contribute to the spread of COVID. And so it's, been a very dynamic process to try to decide in conjunction with schools and local districts how best to respond.
Thanks, Marla, so much. Really appreciate all the public health input as you do every week. Just wanted to go to the kind of the top of the chat and ask a question and then kind of turn it over to Dr. Thornton. This is a question from Kim Joy. She said a patient asked her today about possibly getting the MMR vaccine, Nestor, to protect against COVID. Have you seen any studies or evidence about this?
No, there was some, I remember some editorials and podcasts commenting on the probable use of MMR. And the idea was that if you use a live vaccine, and in this case, these are the combination of 3 live viruses, you can sort of, perk up or stimulate the innate immune system. But I think, and there were some study plans. I haven't really seen any publication of those studies. They were more retrospective. But I think with the availability in the near future of specific vaccines, I think the issue of MMR is taking sort of a second place, and also BCG was also considered as a way to just stimulate the innate immune system. But I think, and it was based on the observation that we saw at the beginning of the epidemic, especially in China, that kids were not affected, or apparently were not affected. But as more countries became affected by the pandemic, we started seeing cases in kids and the multi-inflammatory syndrome. So kids are not really protected because they have multiple vaccinations. So I think that idea has gone down somewhat. I haven't seen the publication of any prospective trial using MMR as a protective. And I think because we're having the phase 2 and 3 of many candidate vaccine, the enthusiasm for MMR has really gone down. But it was a thought. It was a thought based on the observation in kids, and also based on some basic science data on innate immune system. And the observation comes from many years that after live vaccinations of kids, there was sort of a decrease in the respiratory infections with other viruses. And this is historic. So people said, okay, if kids are not affected, if kids after they have vaccination, they get less common cold, maybe it will work for COVID, but we haven't really seen any hard data in that direction.
Thanks, Nestor, so much. Back to you, Carla.
Thank you, Joanna. Marla, I just want to go back to you for a couple of questions. Can you talk a little bit about contact tracing and how that's actually going now that there are so many more cases, and how the Department of Health is able to manage that?
Yeah, as you can imagine, we're really struggling under the increased burden of new cases being identified. And we must contact each of those cases individually and get them on the phone in order to identify their contacts and start the contact tracing. So keeping up with the more than 800 new cases each day, reaching them by phone to make that initial contact, and then getting the list of their contacts, as you can imagine, is no small amount of work. We do have over 200 people, more than 250, I believe, hired through our contact tracing unit, who are dedicated to this work each day. They don't have other job responsibilities. This is what they do day in and day out. And so we have a lot of human resources and, different technology platforms that have been devoted to this process. But as we have more community spread, that contact tracing becomes a bit less effective because people may have multiple exposures and not just the contact that we're identifying. So it becomes a little more difficult to really find all people who've been exposed and make sure that they're quarantining when people may have multiple exposures based upon the community incidence in their location.
Thank you. And just one more, I don't think you mentioned this, but there was a question that came in the pre-registrations. Do we know what specific behavior is pushing the current surge?
If we look at information that we get from contact interviews, or case interviews. It seems to be a variety of things. I think we had this, wonderful period in the late summer where we had very low case counts. And we were all lulled into thinking, maybe we were over the worst of it. And people report an uptick in group activities. So, that can be everything from dining or gym attendance to just, household get-togethers. So people who are getting together with their extended family in their homes. We've seen, an uptick of people reporting that kind of activity as well. And then as, more businesses reopened and people returned to work, there were more opportunity again for those community exposures. So, nothing about the virus has changed that we're aware of. It's just really people's behaviors that have changed that is really driving this increase.
Thank you very much, Marla. Nestor, just back to your presentation, there was a question by Bob Gish about, do you know which interferon was used in the study that you reported about the use of interferon?
No, not really. But they have used, not in the Solidarity, I forgot, but we're using basically interferon alpha and interferon beta. So that's what we're using. And there are trials, both subcutaneous and also nebulized interferon. But I don't remember Solidarity, what were they using really? I have to look back.
Thank you, Nestor. Jeff Miller, do you want to unmute yourself and just ask your question about the oxygen saturation? It's a great question.
Sure, this is Jeff Miller, family practice in Albuquerque. So given that we're at an elevation much higher, 5,000 plus or minus, my question is the pulse ox of 92% or above is often not relevant for many of my patients who are regularly sitting at 89 to 91 and not feeling short of breath. So either in the hospital setting or otherwise, is there a sort of accepted pulse ox reading for our elevation as to when that's too low, regardless of whether someone's short of breath or not?
Right. No, I don't know. I have asked Dr. Harkins in a couple of occasions, and there's some variability in the answer. There's a way to calculate. I'm not a pulmonologist, but there's a way to adjust for the altitude, and you can calculate what the expected oxygen is in a person. But I haven't really gotten a good answer. And for instance, we in some of the clinical trials, it favors us because the inclusion criteria is 94. So it's not difficult to get a person in our trials. So in that way, we give the benefit of the doubt to the patient. If you come with a radiographic pneumonia and a clinical picture of COVID, and you have 93, that patient enters the study because the criteria was not adjusted for altitude in the protocol. So, but I don't really know the specific number. If we, how low do we go depending on if it's in Albuquerque or Santa Fe or some other locale. I don't really know. I can come back to you and ask again our ICU and pulmonary people, because I don't have an answer for that.
Thank you, Nestor. If there's anybody on the network right now who's a pulmonologist or a respiratory therapist or who has this knowledge themselves, they could please they can unmute themselves and educate us, or chat me and I'll call you. I'll call on you. All right. So Nestor, there's a question. Says, given the Solidarity trial, what role do you see for remdesivir in treatment of COVID-19? Do you use it only in patients on supplemental oxygen hospitalized, but not mechanically ventilated?
That's exactly correct. The role based on the Beagle study, the place where we need to use it, it's in patients who have been hospitalized and that require oxygen, basically, because there was no benefit in those who did not require oxygen and very little benefit on those really on mechanical ventilation or ECMO. So there's sort of a small window. And in general, I would say early rather than late. All the evidence points toward, you have to use it really early, not when the patient obviously it's on the way to be discharged or in a way to going into the ICU and intubation. So those are the things. And I think probably in Solidarity, because of the design, it was used on, all over the place. Patient with severe disease, patient earlier, late. So it's kind of harder to distinguish exactly the degree of severity based on their pre-publication, as opposed to the Beagle, in which they actually classify the patient, before getting the remdesivir, so they know which group benefit the most. So I think that's the place, and also remember that we haven't been able to show benefit in mortality. So only shortening of disease by 5 days in the NIH trial, but no more than that. And they enrolled more than 1,000 patients, 1,062, if I remember correctly, and they were not able to prove a statistical significant difference in mortality. There was a trend towards lower mortality, but it was not statistically significant. So it's effective. You can make an argument that it's effective, but it's not a dramatic, really cure or anything close to that. It's just shorten the disease due to his antiviral activity.
Thank you. And one more question about treatment. Deborah McGrew asked, given the dismal news about effective medications for use in COVID, is there a general consensus that dexamethasone is still good, quote, end quote, or effective?
Yeah, dexamethasone is the only one with data from a control trial that show decreased mortality, the recovery trial, and there's a meta-analysis of all the other trials. I think it were 7 trials, and it showed a decrease in the mortality around 40% decreased mortality. And it's in some ways the opposite of remdesivir. Is shown to be more effective somewhat later than early. So people with more than 7 days or 10 days of symptom initiation seem to benefit more. And you can make an argument, although it was not statistically significant, that if you use it too early, it's deleterious. It was a negative result or less of a benefit if you use it really early. So that's basically, but yeah, it's the only thing that has survived the test of time so far, the dexamethasone.
Thank you, Nestor. And Marla, back to you. You may have seen this in the chat from Jeff Miller. It's a really great question, but maybe you can talk about it. Just if there's anything we can do as people in the community seeing people that have COVID to sort of start this process of contact tracing, or any way that we can help, because if the cases continue at this level, it will be impossible, as you know, to keep up.
Yeah, absolutely. Thank you. It's a great question, and there's definitely a lot that providers can do to help us. So when you have a case who you've tested because you suspect they have COVID, even while you're awaiting test results, but also if you're calling patients to inform them of their test results, helping reiterate the isolation guidance for people. I think it doesn't hurt for people to get that guidance from multiple sources and have it repeated, so that they understand, what's being asked of them and what isolation means. Asking them to think about the people that they've been in close contact with in the 2 days prior to their illness onset up until the time they're isolated, or in the 2 days prior to their test collection, and really getting, those names and phone numbers organized so that when the case investigator reaches them, they've got that information ready. Very often people say, well, I don't know, I'll have to think about it and get some information together and call you back. And that just delays the contact tracing. So asking people to start thinking about that when they've been informed of their positive test results would be very helpful. And then we, often ask people when we have them on the phone and we inform them of their initial test results, if they've let their close contacts or their employers or their other family members know that they're positive. So also nothing stopping your patients from reaching out to people that they know they've been in close contact with and giving them that heads up so that they can start their quarantine immediately and they're not waiting, necessarily for someone from the Department of Health to call and give them that guidance. And even if a person tells us they've already spoken to their close contacts, we'll collect that information and reach out to them as well, because we do try to monitor contacts through contact tracing. It's still something we're trying to do. We were, monitoring people daily. We're now doing it, every other day, checking in with people we know who have been exposed to see if they've developed symptoms or had a positive test. So we still are trying to keep up with that. But definitely there's a lot you guys can do to help us in terms of getting that messaging out and asking people to start thinking about their contacts. So again, it's 2 days prior to their illness onset, 48 hours prior to their illness onset, up until the time that they're isolated. or, the 2 days prior to their positive test if they're asymptomatic. So thinking about everyone they may have been in close contact with during that time period and getting that information organized so they're ready when they are first contacted is very helpful.
Thank you so much. And before we leave the public health, everyone's very interested in this at this moment, but David Tempest asks, is there any value in testing people who are not close contacts, not symptomatic, and not in a congregate setting? Or does this have any surveillance value, or is it just wasting tests?
Especially when we, don't have a lot of widespread activity, that surveillance testing, is a bit more useful because you're identifying disease where you don't know disease exists. I think from a testing capacity standpoint, people who are symptomatic and people who are known contacts are always going to be a high priority for testing. And then, sort of cascading down from there to the general public when we have testing capacity available. So always, prioritizing symptomatic folks and people with known exposures.
Thank you very much. So Nestor, I'm going to go back into the pre-registration questions. Are there any treatments or any information on residual COVID effects such as altered smell or hair loss? Let's see, I'm not sure quite understand this question. Cindy, it's HOANG. Are you on the network? I don't see her. Let's see. Nestor, one of the questions came from Christy Thomas in Columbus, New Mexico. What are the biggest barriers to vaccine development and distribution so far?
Well, I think let me start with just vaccine initially. Obviously, this is a new virus, so a relatively new virus. It's been around for less than a year. So I think developing a safe and effective vaccine and test it in enough people that you can generate, the confidence of the public, I think is the biggest hurdle. And really, to be honest, it had moved tremendously fast. I mean, I have never seen from genome in January to the first phase 3 studies in September. It's been amazingly fast, and we are, going to have a vaccine, at least some data of preliminary efficacy and safety in December. So I think it's amazing. But I think the fact that it's new, and some of the platforms that are being used have not been used in vaccines previously, like the mRNA. And some others are relatively new, using nanoparticles or a mix of 2 different adenoviruses. So there's a lot of new technologies that are included in this vaccine. So that's what is so critical to look at the efficacy and safety data. And then distribution is going to be another issue because initially, obviously, the production is going to ramp up, but it's going to be gradual. So actually, most of and Marla can comment on this, most of the states are preparing to do sort of a stage-wise deployment of the vaccine. You're not going to, open the vaccination like we do with the flu, that it's in every Walgreens or CVS. It's actually something that's probably going to be like a stage 1 for healthcare workers, then to another level, then another level, and probably well into the 2021 we'll have more data. And the other thing is that the vaccine is initially being studied in adults, young adults. So we need to gather enough data in elderly folks and also in pediatric population before it can be granted approval. So it's going to be some time for that, and also for the production and distribution. And this is something that is going to occur worldwide. So some of these countries, some of these companies are actually working with all the governments and with WHO and Gavi and some other multilateral organizations to get the vaccine ready for distribution. So I think it's going to be, something that we've never seen before, ever, with this degree of coordination and collaboration across many states and countries for this vaccine to be available. I want to make a comment on the contact tracing. Obviously, I'm not an expert. I'm like really learning by reading and seeing the comments by Marla. But there's also something important that I think is important. I have seen a couple of papers on something that people call reverse contact tracing. It's actually when you when you see a patient, you try to see who they may have infected, so that's why we go 48 hours before and forward. But actually, if you can identify who infected that person, if you can say, okay, this person went to a rock concert that wasn't not allowed, but he was in a rock concert 10 days ago, or was in a birthday party with several people, that's also important. It may be beyond the 2 days that the person is infected, but you can actually find another or find a super spreader event or some interesting activity that may have happened a few days before, because remember the incubation period of the disease is between 5 and it's between 3 and 14 days. So the person could have been infected a week before when they went to Sturgis in the motorcycle event, for instance, and you can actually, obviously, you can track down, and if you find that extraordinary event, you can actually discover more people and do some more testing using that reverse contact tracing. It's kind of complicated because people don't always volunteer that they went to a party or they had like this huge gathering, but it's something to think about when you see a patient and ask them, have you been, together? Have you done a party? Have you been to some type of congregate setting, to the church, and they actually meet inside the church, or this something, even if it's not allowed by the current rules, it's important to identify other people that may have been infected in a spreader event.
Thank you, Nestor. Dan Saltman, do you want to unmute yourself and ask your question? It sounds like several people are interested in that.
Sure, thank you, Nestor. So, and that study you showed at the beginning of your talk that you reviewed, the median duration of viral shedding was longer than what we usually use as the standard for return to work or end isolation recommendations. So which I think is 10 days after either the positive test or the end of symptoms. So how would you comment on resolving that recommendation, or if there is need for an update of that recommendation based on that study?
Right. Yeah. Thank you for the question. No, actually, I do not. And let me just remind you, this study was actually a review of 77 studies. So it was very heterogeneous group of studies. Some of these viral shedding were from patients who were really sick in the ICU, especially from the early part of the epidemic. Most of the reports were from patients really severely ill. And we know that those patients can have viral sheddings over the usual 10 days. And that's, I think, why the recommendation from CDC is 10 days for those with regular COVID, but those with severe or critical COVID and those immunosuppressed should maintain the isolation for 20 days. The duration of the infectious viral shedding, it may be longer in some individuals, but when you take it as a population-based analysis, I don't think it changes much the recommendation. So I think it's, although it obviously opened the window a little bit more, but probably I don't think it should motivate a change in the recommendation for now, because most of the studies show that the infectious virus goes down after day 8 of symptoms. So definitely by day 10, unless you're immunosuppressed or are in ICU with very, very severe COVID, it should be okay.
Thank you, Nestor. Cindy clarified her question. She says, I'm a PCP in a primary care setting. I'm seeing patients that were infected with COVID several months ago, but continue to have an altered smell and have increase in hair loss. Are there any studies or information about these symptoms post-COVID, or about treating them or helping these patients?
Yeah, no, I haven't seen any on treatment, any specific good recommendations on treatment. But in fact, yeah, there have been some reports up to 60 days and post-COVID that people may be experiencing these symptoms. And the most recent that I've seen is hair loss. Before, we had a lot of attention in the loss of sense of smell and taste, but obviously also, as I mentioned, fatigue, respiratory symptoms, and issues with concentration, memory, and sleep disorders. All of these have been reported to last longer than 2 months after COVID in some patients. So yeah, it's something that we've seen. I don't know about management. I haven't really seen any specific recommendation for any of these, except for like rehab for pulmonary rehab, physical therapy for those who have fatigue, but really nothing specific regarding like an intervention or a therapy. I think the next step will be to try to study the pathophysiology to see if this is an immunological thing, it's a virus in a sanctuary place. Still don't know. So I think understanding that will help us find some effective treatment. Although I'm not very optimistic, because really with chronic fatigue syndrome and other post-viral syndrome that we know for many, many years, there are not great therapies. I mean, there are people, testing different therapies, but there's not like an accepted, dramatic drug that can actually change the course of the disease in the short run.
Thank you very much. And I just wanted to let everybody know that the CME link just went into the chat if you're interested in getting CME, and we would love to have your feedback as well. Nestor, Fred Fox asked a question about the rapid antigen test. The Binax now, it's apparently being distributed to the states. This question is, has New Mexico received these? If so, how many and how will they be distributed? Do you have that information?
No, I don't know if Marla, I do not know. We're still using TriCourse PCR essentially, except for very few that we have for like patients that are going to go through our emergency procedures or other. We have a very limited number of rapid tests, but for the great majority of patients and even asymptomatic, we're doing PCR on all of them.
Thank you. Marla, did you have any other comments?
Yeah, we have received some of the Binax cards here in New Mexico, and I have an email somewhere talking about that more that I was looking for that I can't find. But some facilities like nursing homes have received Binax cards shipped to them directly. Some have been shipped to our state public health lab, and so the state public health lab is sort of the steward of some of those resources right now in terms of helping decide the appropriate use for those Binax cards in monitoring of facility-based outbreaks, for example. They really, much like the other antigen and rapid point of care tests, are really only indicated for people who are symptomatic. So not being deployed for screening testing in a widespread way right now.
Thank you, Marla. And I think we have time for one more question. Mark Umberzat, do you want to unmute yourself and ask your question?
Sure. Hi, Mark Umberzat here, primary care in Albuquerque. I was wondering if I tuned into the Global Echo conference about a month ago, where one of the presenters from the Netherlands showed some data where they had an outbreak in a nursing home, and they thought it was attributed to people attending a church service and then visiting the nursing home. And then she showed the genotypic data, which contradicted that. I'm wondering if New Mexico is doing any of that genotyping to help confirm or just to help support the epidemiologic tracing. Thanks.
Thank you, Marla.
Yeah, the Department of Health is doing some of that work in conjunction with CDC and Los Alamos National Labs. The time frame for that, though, it's not sort of available quick enough to be used for current case investigations and current contact tracing. It's more for epi understanding of disease transmission and trying to see if specific outbreaks are linked to each other in the way that we maybe thought they were based upon case investigation and contact tracing data. So it's more of a epi surveillance tool right now than something that's available rapidly enough to be used in active contact tracing or case investigation.
Thank you so much. Well, thank you everyone for joining today. I just wanted to remind everybody to fill out the CME if they are interested and if you give us feedback. I wanted to let you know there's a first responder echo this afternoon from 2 to 3, and the topic is police peer support response during COVID-19 pandemic, which sounds very interesting. And the next critical care echo is not this week, but will be next Thursday, November 5th from 8 to 9 with Michelle Harkins. And please visit our website if you have if you would like to look for other resources, and we're very happy to have you join this every week. If you have questions, bring them back next week and we'll have another session. So thank you so much for joining, and we'll see everybody next week.